I'm going to do that. Good morning, everyone. My name is Anita Day. My pronouns are she, her, and I'm Chair of Worcestershire Acute Hospitals NHS Trust. Today is Thursday, the 9th of February, and this is a meeting of our Trust Board in public. I'd like to welcome members of the board and other colleagues who are joining us on MS Teams, and also wider staff and members of the public who may be joining us via YouTube. You're all very welcome. I'd like to give a particular welcome to 3 new members of our board who are joining us as official members of the board for the first time. They are Tony Bramley, Michelle Lynch, and Karen Martin, who are joining us as 3 new non-executive directors. The eagle-eyed amongst you may actually have spotted them last month, where they were with us as observers. The reason for that was that at that point we hadn't had official notification from NHS England of their appointments. Regrettably, we still haven't got every single piece of the official stuff sorted today, but we're very, very close, and therefore I'm delighted to welcome them to our board, subject to those final bits of checks. We very much look forward to working with you, and thank you for agreeing to take on these important roles. As board members will know, it is our custom to start our trust boards with a patient story, and those of you that have looked at the agenda will see that that is not happening today. That's a very deliberate decision on our part. I'm sure everyone is aware of the unprecedented and sustained pressures that our organisation and our colleagues are facing. And in the spirit of putting patients first, it seemed that the best way we could do that and role model that would be by actually allowing our colleagues the chance to get back to their jobs, to caring for our patients, whether directly or indirectly, and being able to do that as quickly as possible. We're therefore going to treat this board in a very targeted. We're going to handle it in a very targeted and focused way. We will, we have asked all presenters to treat all papers as read, and to bring to our attention in their presentations only those things that either require escalation or that they particularly want to bring to our attention. Everything else will be taken as read. As regards the patient story, this is not a permanent change. We very much hope to get back to that as quickly as we can, but for this particular month it seemed the right thing to do. So, moving then in that spirit of doing things as quickly as we can and as efficiently as we can, I'd like to go to apologies for absence. I have one from Richard Oosterham, but no others that I've been notified of. Moving to items of any other business, I've not been notified of any. Does anyone want to raise anything now that is not on the agenda? I don't see any hands, so I'll move on. Declarations of interest. I haven't been notified of any specific ones to do with the agenda today. Obviously, our normal declarations are on the website in the normal way. We then move on to the minutes of the previous meeting, which are in your packs. I'd be grateful for your confirmation that they are a true record of the meeting, or if anyone's got any points, please shout now. Matthew.
Yeah, thanks, Chair. Just in reference to the comments I made at the last meeting under my Chief Exec's report about the incident on the 20th of December, I just need to add an addendum to the minutes that, in fact, the decision to offload the 18 ambulances into the emergency department Worcestershire was actually a miscommunication between the Midlands region and the West Midlands Ambulance Service. I've learned subsequently, so I think it's important we put the record straight that it wasn't a decision taken by the Director of Performance. It was actually a miscommunication. Nevertheless, the rest of the comments stand in relation to making sure communication is more effective. And Simon Trickett and I have met and discussed how together we can work with colleagues across the wider system to make sure that we don't have a repeat of this incident. But otherwise, it's important to put the record straight. Thank you.
Thank you, Matthew, for that clarification. Jackie.
A small one, Chair, please. Under the quality and safety that I was discussing at the last meeting, C. difficile, it says had reached target. In fact, that's a typo. We're missing a B. It's breached, unfortunately. Thank you.
Thank you. Thank you, Jackie. Simon.
Just a question to, I think, Paul on the theatre utilisation accountability framework that's referred to in the minutes. Was that eventually signed off by TME? And I just have to ask Matthew, what exactly was the nature of that miscommunication given the catastrophic effect that it had?
If I can come back on the first point, Chair, it was signed off at the theatre group 2 weeks last Wednesday, and it's going to TME for approval in February, but it's been implemented.
Okay, thank you. Matthew, I don't know if you can say any more.
Yes, not to dwell too much on this, but the instruction for ambulance services ahead of an ambulance services strike is to make sure that any patients that are on an ambulance over 15 minutes are brought into the emergency departments. To an hour is the policy that had been put in place, and that was misinterpreted on this occasion. Thank
you, Matthew. I don't see any other hands raised. Are we happy to take the minutes as a true record? I see some nods. Thank you very much. Moving on then to the action log. Rebecca.
Thank you, Chair. The updates are as per the log, and I should be aware we've been having an ongoing discussion about the board work programme and how that features into the board development plan, so these points will be addressed in due course. Thank you.
Okay, right, thank you very much. Okay, sorry, Simon.
Just on the behavioural charter, I think I'm right in saying that it might have been the chair of the BAME network who could have been attending this meeting today. I might be wrong on that, but I just wanted to thank Tina and Richard for the meeting I had with them after the last board, where they updated me on progress with the behavioural charter, and note that it's in Worcestershire Weekly again this week on raising awareness about behavioural charter. But I still sense there's a little bit more we can do to actually make a difference and embed this so that people know exactly what to do when they need to do it if they feel they've been victim of discrimination or bullying. And I'm just wondering what other things we can do so that we can perhaps monitor any increase in incidences. Have we seen an increase in incidences, which one would expect if this was making a difference and people would know what to do? So it's an ongoing conversation we're having, and I know we're due to do this as a board development session at some stage, but having been to the BAME network myself this week, I think I just needed to reflect back that there's still a feeling that maybe it hasn't had the impact we hoped, despite all the best efforts that have been put in place, so that people know immediately what to do if something happens to them.
Right. Tina, I was going to suggest that we perhaps took the answer to Simon's question as part of your, when we come to the people and culture part of the IPR, but if you'd like to respond now, you're welcome to do so.
Just briefly, the honest answer is we're nowhere near where we need to be right regards to the implementation. That's still work in progress. So it will take a while to embed. Happy to take more detail through to the people in culture or attend a non-exec director meeting to provide that background if that would be helpful.
Okay, thank you, Tina. Okay, so that's the action log. I see no other comments on the action log. Let's move then to the chair's report. I'll take that paper as read. You'll see that I had to take several chairs' actions over the last few weeks. All were in line with Finance and Performance Committee recommendations and our standing orders. And just to mention, in fact, just in the last couple of days, I've had to do another one, which happened after these papers have been issued, and which we will bring before board at the next board meeting. But I should be grateful for the board's ratification of those chairs' actions, please, if you could indicate your agreement. Again, I see some nods. Thank you very much. I'll do that. Just before I hand over to Matthew for his report. I just wanted to say one thing. I mentioned in my opening the fact that we're all very conscious of the pressures that we are currently experiencing. I think it's only right for me to, on behalf of the board, make an apology, to say sorry really to two groups of people that are perhaps the most important, well not perhaps, are the most important people here. The first is to our staff. On behalf of the board, we'd like to say sorry for the fact that these conditions that you are having to work in are continuing and have been continuing now for several weeks and indeed months. The second group is of course our patients. We know that because of these pressures, we're not now able to perhaps look after you in the way that we would wish to do. Perhaps you're having to wait a little longer for your treatment. Perhaps we're not doing things in the way we normally would. I'd like to say sorry to you too. I know because you tell us, we know that you understand the pressures we're under, and I'd like to thank you for your understanding. But can I, on behalf of the board, just reassure both our colleagues and indeed our patients that we are completely focused on doing what we can to try and improve the situation as quickly as we can. And I'm sure many of the discussions that we'll be having through the rest of this board will absolutely reiterate that. Having said that, I'd like to now turn over to Matthew. Thank you.
Thank you, Chair. Morning, everybody, and echo your comments, Chair, in reflecting on the continuing challenges that we're facing in giving the patients we're looking after the best healthcare in line with our vision statement. Having said that, there's a couple of elements in my report that do point to quite significant progress in improving the patient safety and the quality of care, not least the launch of our electronic patient record. Board members that have been around for a few years will remember we signed off our digital strategy, first version of that, in June 2019, and it's wonderful news to be able to report to the board that we started a few weeks ago with pilots on 5 wards, and this week on Wednesday we went full throttle at the Alex Hospital with the rollout of two key elements of the electronic patient record, and so far so good. Good adoption of the new ways of working. Clearly this is going to feature as part of our ongoing oversight as a board over the course of the next few years, particularly in relation to the benefits realisation for our patients in receiving safer care. And we also took the opportunity to welcome Tim Ferris, the National Director of Transformation, the NHSE Director responsible for the electronic patient record rollout. We welcomed him to Kidderminster as a system, and we took the opportunity to talk him through our plans, also how they link closely to our forward improvement system, which he's also responsible for the oversight of transformation programs at NHS England, and I think we've developed a fruitful relationship with Tim going forward. I think we're keen to make sure that relationship continues to thrive. I do want to draw the board's attention to the continuing difficulties relating to the industrial action that's affecting the NHS and the public sector. Earlier this week we had Royal College of Nursing and ambulance workers taking industrial action, and we did our level best to mitigate the impact on patients, where there were no cancellations of outpatients diagnostics or operations on Monday or Tuesday as a consequence of the industrial action, albeit that we had planned some changes to activity levels ahead of that. I would just like to take the opportunity to stress how important it is that a resolution to all industrial action affecting the NHS is found as quickly as possible, because there is impact on patients, there is impact on staff, not just those staff that you might think of more readily, nurses, doctors and others. I'm particularly concerned about our administrative staff and the impact on them of having to cancel and rebook patients as a consequence of the industrial action, and this impact will last for a long time. So I stress again the importance of a resolution at national level, at government level, being found as quickly as possible. Just a couple of points for members to note in relation to the wider system. The Integrated Care Partnership and the Integrated Care Board continue to set out, I think, quite clearly now the priorities for Herefordshire and Worcestershire, and I think as a board we will want to make sure that we are considering and responding to the joint future plan as that develops. And finally, just to reference our continuing work with our local partners and our tertiary partners to build the right type of strategic partnerships for the benefit of our patients. And we recently had an executive team meeting with the executive team at University Hospitals Coventry and Warwickshire to compare notes, to look at closer working and to share progress, particularly in relation to our improvement system, because of course they are an existing Virginia Mason Institute partner organisation, and how we might work more effectively together with robotic surgery. So the final thing that isn't in my report, Chair, just to note, is we are making progress to seek to replace the irreplaceable Chief Operating Officer Paul Brennan, and interviews are scheduled for the beginning of March. So I'm hopeful that come the next meeting I'll be able to report the outcome of those selection processes. Happy to take any questions. Thank you.
Thank you, Matthew. Any questions or comments on Matthew's report? I don't see any hands raised. I just want to reiterate Matthew's comments about the need for a national resolution to the problems relating to the industrial action. This is affecting us, but it's affecting every single trust and healthcare provider across the country. And yeah, we absolutely need some help really from the centre. Tina.
Just for awareness, we've got the Charter Society of Physiotherapy industrial action today, and we have got picket lines on our Worcester and Addex site for the board's awareness.
Yes, thank you, Tina. Okay, so thank you, Matthew, for your report. Let's move on then to the Integrated Performance Report. I wonder if, with board's indulgence, what I'd like to do is tackle this in the way that we did last month. In other words, rather than go through all of it, I'd like to perhaps to call on the individual executives to give us their sort of their highlights or the things they wish to draw to our attention in certain specific areas. And the areas I would like us to focus on will be elective care, cancer care, urgent and emergency care, patient safety, people and culture, and finance. Of those first three, I guess that's Paul. So cancer, elective, and urgent emergency care. I wonder, Paul, if you'd like to give us your highlights, please.
Yeah, certainly, Chair. I think it's probably helpful, given the circumstances, that I give an updated position, because clearly the IPR relates back to the previous month.
Yeah, so, and Paul, sorry, what I'll just say is if you do one section at a time, and I'll pause and get any questions at that point, and then we'll do the next piece, as it were. That would be great. Thank you.
Yeah, well, if I pick up on cancer first, board colleagues will remember that the number of patients that we had breaching the 62-day standard in October was 814. And we'd set ourselves a trajectory to get that number down to no more than 328 by the end of March. The current position is a halving of that number. We reported last week the number waiting over 62 days is down to 401 against our trajectory of 561, so well below the trajectory, and a complete halving of the delays over 62 days. We looking forward into the actions that we've got in place. I'm confident that we will hit that 328 trajectory we agreed in October, and I suspect we will come in slightly below that, looking at the way the clinical teams are working, particularly around colorectal and skin, where we expect skin to have dropped from about 300 to 0 by the end of the year, and colorectal to have halved from a high of 120. Clearly the most challenging tumour site remains urological tumours, and of that 401, urology accounts for just over 200. So that's the position on cancer.
Let me just stop there. Does anyone have any questions or comments on that update? I don't see any hands. So Paul, first of all, our thanks. That sounds like real progress there. So that's really encouraging to hear. In terms of the urology issues, are there, what actions are we taking at the moment to try and make a dent in that number?
So the reason part of the reason the number is high is because we've put in place at the front end of the pathway some significant improvements, which means that we're seeing patients and diagnosing them much quicker. So we've now gone to 93% on the 2-week wait standard from 12%. So we're seeing, on average, we're now seeing and triaging patients within about 4.5 days of referral. And as board members will recall, we allocated the mobile MRI scanner at Kidderminster as a priority resource for patients on a prostate cancer pathway. So that has meant that we've gone through the diagnosis a lot quicker. And colleagues will also remember we had a contract with a private sector entity to work at the ALEX at the weekend on the LAPTs, the biopsies, the local anaesthetic biopsies. So that has all brought forward the front end of the pathway. And so what our focus, which is good because that's doing it, but that's keeping the overall numbers high. So our challenge now is around those that are waiting for surgery. I have to say those numbers are small. We currently, on the active pathway, we're now down to 4 patients who are waiting robotic surgery at the ALEX. And as colleagues are aware, the proctor signed off our 2 clinicians, so they're now operating solo, which gives us the opportunity to create a bit more capacity. And we had a discussion with colleagues from the National Cancer Team last week and agreed that we should shift all our prostatectomy surgery to robotic, and that will give us 1 extra robotic session a week that's currently used for open. And then the other areas are those on waiting for therapy, hormone therapy and radiotherapy and chemotherapy. So our focus now is on the latter bit, having resolved all the issues on the front end of the pathway.
Great, thank you. That's very helpful. Elective next?
So elective, as colleagues will know, that we set out with a plan to achieve no one waiting over 78 weeks by the end of March, from a starting cohort position of 23,900 who would breach if we did nothing. The position as at last midnight last Thursday, our trajectory had that number down at 2,447 and our position was 2,250. So we were 190 below trajectory. Our trajectory for midnight tonight is 2141, and our position on Monday morning was 2158. So given that we'll have another 3 more days activity, we expect to be below the trajectory again. Clearly though, there is a big challenge that number of patients waiting for the 2,158 left. We've got around about, well, we've got 710 of those patients have been seen, listed for inpatient or day case surgery, and our aim is, of those 710, there's 461 still to date, and our aim is to date all of those by a week tomorrow, the 17th of February. We have, and then within there are 668 patients who are waiting for a new outpatient appointment. We've managed to push that on quite significantly, and of that 668, we've now dated 435, so 233 to go, and our aim is to have dated those by next Wednesday. So at the moment, we're still reporting a potential risk of 400 patients breaching 78 weeks at the end of March. But we're working, as you can see, trying to get all of those already listed dated by, as I said, a week tomorrow, and then focus on not only dating the 233 new outpatients that remain undated, but seeing the whole 668 by the first week of March is our aim. And clearly the key issue there for us will be, this is where the risk is of the conversion rate, and then having sufficient time and capacity to operate on those. We are working with the ICS colleagues about the potential of some of the less complex cases going to the independent sector, who have indicated but have not confirmed that between now and the end of the year they could potentially see 385 patients. So we're kind of dealing with our own internal activity and then seeing whether that 385 is a realistic offer from the independent sector. And just to assure board members in terms of the financial position, this is all that subject to additional resources coming from Jim Mackey as the National Director and Head of Elective Care. So we would only go down that direction if externally funded, so it won't have any negative financial impact on the trust. So we've gone from, in summary, we've gone from just under 24,000 in the cohort to 2,250, which is just under 200 above plan, and we expect to be, or should I say, below trajectory, and we expect to be below trajectory when we report tomorrow.
Okay, thank you. Questions or comments? Nothing? You're obviously blinding them here, Paul, but blinding them with science, and they can't think of anything to ask. Oh, Matthew, you wanted to come in.
Yeah, I think it's a really helpful update from Paul. I think the key thing for the board to note, though, is of course that our ambition was always and should continue to be to get to 0 78-week waiters by the end of March. So we mustn't lose sight of the need to get down to that number, as was the previous discussions here and commitment that we made. And I know Paul and the team are totally focused on that.
Yeah, absolutely. But it does sound like some real progress is being made there again. So congratulations to the team for all their hard work. Urgent and emergency care.
Well, I'll pick up on, I think, maybe 3 issues. 1, ambulance handovers, 2, length of stay, and thirdly, discharges. So in terms of ambulance handover delays, we know that it was a really challenging week running up to Boxing Day. And for the week ending the 26th of December, the hours lost from ambulance handover delays was 1,473. Well, everyone will be aware since then, the teams have put in some real considerable focus to try and reduce that. And we've also had a number of industrial action days since that period. I can report that the position has improved quite significantly. For the week of the 2nd of January, that number reduced to 825 hours. For the 9th of January, down to 306 hours. The 16th of January, down to 128 hours. The 23rd of January, down to 48 hours for the whole week. We then had more of a challenging week for the week ending the 30th of December, but the hours lost went up to 421, which is clearly still well below the peak in December. And for last week, for the week ending the 6th of Feb, the number dropped again quite significantly to 186. So, and we all know, we all have to accept that the answer to this question is supposed to be nil. But I think the improvements made since that week, that Christmas week, have been substantial. And although we had that difficult week, the 30th of January, I think we have shown for 1, 2, 3, 4, 5, 6, 7 weeks on the run now, we have sustained a much lower number, which has been somewhere between 50% of that high and down to 5% of that high. So I think that is still more work to do, but positive. In terms of length of stay, the main focus there has been on both sites. On the Worcester site, what we've actually seen, length of stay at the moment is starting to drop slightly, but is currently running at 8.92 days, the average length of stay. And if you compare that to the same period last year, so in 2022, that is 1.33 days higher on average than it was a year ago. When you look into that, the simple discharge average length of stay is currently running at 6.31, and that is comparable with the position in February last year. Whereas the complex discharges, if you compare to the same position last year, they're running about 1.95 days higher than last year. And in particular, if you take the same week, Pathway 1 discharges are currently running just over 4 days. Average length of stay is 4 days greater than it was last year. So we have seen, it looks as though the increasing length of stay is actually being driven via the more complex discharges. Having said that, the reverse is true in relation to discharges, where we have been closer in achieving our total number of discharge standard on complex discharges than we have on simple. Although the simple discharges have now increased to they're at a low of 66%, I think it was. They've now increased to about 87% of the target, and pathway discharges have been running at about 93% of the target. The target for the trust is to achieve 740 discharges a week, which is basically turning over every one of our G&A beds within a week. So I think on the urgent care, positive improvements on ambulance hours delayed, challenge on length of stay, although demonstrating that it's dominantly in the complex, an improving position on discharges, but not achieving the 100% or the 740 that we need, and particularly tough days on a Monday, when that's the day that we need to achieve the maximum number of discharges, which is 130 across our 2 hospital sites, and we've been running on that day round about 80 to 90, and then that is backing up problems into the rest of the week. In terms of just one additional thing that we've agreed as a ICS, some colleagues may recall that we've had visits from Ian Sturgis in the past in his role at NHSEI. Ian no longer works for NHSEI now, and he's working as an independent consultant, but as you'll be aware, he is very focused on discharge and ensuring that we're not decompressing patients, particularly older patients, and a focus on home for assessment rather than assessment within hospitals. So we've asked Ian to come in for 2 weeks to undertake an update review, but he's doing this on our behalf, so it's not working for NHSEI. It's something that the ICS has commissioned, and Ian will be coming in to work through with our clinical teams, both in the acute and in the Health and Care Trust, for 2 weeks commencing the 27th of February.
Okay.
So that's where we are.
Thank you, Paul. Simon.
Thanks for the update, Paul. Very detailed information there. Could I ask what the update is on the Onward Care team? Because I think there's been a bit of work done at System there, which might be related to discharges, and what progress there is on the community ward being co-located on the Royal site. And then also, could I just sense check something that's in the IPR on the flow diagrams on avoidable attendances?
Yeah.
Am I correct in thinking, say, for example, the Royal one, basically we're talking about over 1,000 avoidable ambulance attendances? Is that the correct reading of what that diagram says?
Do you know what page that's on?
I think it's 35 to 38. I'll just scroll through myself as well.
So in terms of your questions, the Onward Care team report has been completed. There was a ICS-wide session to go through the report a fortnight ago. As a trust, we've accepted the recommendations of the report. County Council and Health and Care Trust colleagues wanted to have further internal discussion on the recommendations contained in the report, and there is a session booked for the 20th of February to fully release the report and sign off all the recommendations. But as I said, we have accepted all of the recommendations. We're just waiting for confirmation that that is also the case for the Health and Care Trust and the County Council. In terms of your second point, which was progress on the community ward at the Royal, the answer is nil, and it's not going to happen. That's the position. And I'm just having a look at your comment on.
Yeah, so the flow diagram there suggests 1,101. It says ambulances, potential ambulances avoidable. So I'm just clarifying what that means.
The difficulty with this, and the chair and myself have had a discussion about this. We've done some analysis of avoidable attendances, both conveyance and walking. And that's done on the basis of the presenting complaint, which I think can in some ways overestimate the avoidable attendances, because there can be complications linked to the reason the patient is presenting, not just on the presenting complaint. So I've asked for a bit more work to be done on that to see if we can hone it down, because there is a risk that we could be taking a view that the avoidable attendances are higher than they actually are.
Yeah, I think that would be helpful, because obviously it's a public-facing document, and you wouldn't want people to get the wrong end of the stick if we're still a work in progress on this.
Simon, did you get all your? There were a couple of questions in there.
No, that's fine. It's
That was it?
disappointing,
That's finished?
disappointing
Good.
news about the community ward, but I guess those are conversations that will be ongoing.
Yeah, absolutely right. Thank you, Colin.
Thank you, Chair. Paul, I'm cautiously optimistic that I'm interpreting your news on ambulances correctly, and that we've weathered the storm, and that there are real signs of improvement. And I guess my question relates to how confident we are that we know those factors which have driven that improvement and how sustainable they are.
So, I mean, as I said, we have had 7 weeks of sustainable improvement, albeit we did have the increase the week of the 30th of January. In terms of what sits behind that, part of it, to be blunt, is that we have utilised the corridor in ED for offloading ambulances. Secondly, we have maintained our SEDEP units as non-bedded areas and stopped having patients overnight, and they have increased their pull and the push from ED into there. So we're getting round about 8 to 9 more patients a day going to medical SEDEC or AEC in the new unit over in Aikenbury, and so that's averaging about 25 a day now. And of course, we've now got the surgical assessment unit in the old white space, and that's pulling an average of around about 12 patients a day. So we're seeing pull and push into the 2 units, which is assisting in ED. And as I said, we have been using the corridor. My earlier comment though on length of stay and discharges, we're not going to be, to be blunt, we're not going to be in a sustainable position until we're achieving our discharge target, because we are still facing 20 plus patients waiting to be admitted in our emergency department at kind of 5 o'clock in the morning every day. So we have not resolved the turnover we need in our inpatient capacity, and that element needs to be delivered before you can truly say we're sustainable. But 7 weeks on the run, linked to the AECs, the 2 ones, surgery and medicine, have made a big difference.
Thank you, Paul. Karen.
Thank you. It's just a quick one, really, just again going back to discharge and length of stay. Just to understand, is there any plan? I mean, it may be in the current plan or in hand, and I've just missed it, to use the improvement system or to look at an RPIW on the discharge work. You've mentioned Ian coming in. I didn't know if that how that was linking together with that, or if there is any plan for the future.
Yes, there is, and Christine's leading on that, so Christine might want to come in on that point, Karen.
Thanks.
Yeah, thank you, Karen. Yes, patient flow is one of our first 3 value streams for our forward improvement system, and we have been focusing on the discharge process, particularly for simple discharges. So we've had our first RPIW on the process leading up to completion of the electronic discharge summary and prescribing the TTOs. Our next RPIW, which is coming up, is looking at supply of medication for patients that we're discharging, and we will be using one or both of our discharge lounges as the Gemba for that.
thank you. Simon, I think that's a legacy hand, I'm guessing. Okay, just one question from me, and this may be better directed to either Christine or Jackie. Clearly we have got a focus on discharges and discharging patients as promptly as we can. Can the board get assurance that there is no patient harm resulting from that we're not, discharging people perhaps prematurely in terms of readmission rates or anything? Are we reasonably confident that that actually that process is going well and is safe and is appropriate?
It's an interesting question, Chair, because what we've picked up in the last few days is that we've seen an increase in readmissions on patients discharged on Pathway 1. So we're currently doing, with County Council and Health and Care Trust colleagues, a review to see whether that there's any sort of link there to earlier discharge. But that's the only area where we've picked up any movement in readmission rate, and that's patients being discharged on Pathway 1. But I can't say it's as a consequence of that at the moment. Yeah. We only picked it up this week.
Yeah, thank you. Christine.
And I would add that this comes into our thinking in terms of balancing the risks in earlier discharges. So we certainly have patients who are keen to go home with support in their own home on Pathway 1, that we know that the discharge could be risky, but we want to respect their wishes, and we're balancing that risk against the risk of patients waiting in the community for ambulances or waiting outside our hospital on the back of the ambulance.
Yeah, absolutely. I mean, this is a judgment call and it's a balancing act. I absolutely appreciate that. Jackie.
It's to add into the holistic picture that we're also picked up that we're seeing quite a number of patients whose carers are really struggling. And so that's with regards to readmission due to, actually, whilst packages are in, the carers themselves are really struggling. So we are working as a system actually, and looking at and with the Carers Association of what is it that we can do and are to the possible to really improve that support, but to actually really understand what it is like for carers, and there is a significant impact that we just need to recognise.
Thank you. And yes, I think this is, it's reassuring to know that the work is underway, and we want to understand that further. So thank you for that, and I'm sure we will keep we will be keeping an eye on the possible the data that you've that's come to light on Pathway 1. Okay, moving then through the IPR, I'd like to ask Jackie, if I may, to just give us some highlights regarding patient safety, infection prevention and control. Is there anything you'd like to draw to our attention in that area, please?
Yes, thank you very much, Chair. So looking at the sort of all of the metrics, each of which are important, assurance levels that are provided, I think certainly for falls, friends and family complaints, are within that sort of range of assurance. The one area, as you quite rightly mentioned, for us, which is our key priority from those metrics, is our infection prevention and control. We had a NHSI visit in October, and our report came through last month, and we've been very actively working on that action plan and findings within there. We are expecting a revisit in March, but what we found from that visit and the key messages is that we were green. They have not changed the colouring of the green, but what they have added in is enhanced monitoring. And we have had our first tabletop meeting with NHSI with regards to that, and they are assured with regards to our action plan that we have in place. December, as we all know, we did see a number of outbreaks across our ward areas, mainly due to the increase in incidence of flu and COVID. in January, that is very much settled. We are very focused on C. difficile, and that's predominantly our focus with regards to estates management, and actually getting back to basics with regards to hand washing, raising awareness across the areas. Those are the key messages for us. As I said, it is a system-wide approach. When we have benchmarked ourselves with other organisations, we're sitting sort of within that sort of top quartile, but nowhere near the top within that top quartile. But we're working very much with that learning across the system.
Right, thank you, Jackie. Any questions or comments for Jackie? I don't see any, so thank you very much. Tina, have you got any quick highlights you want to share for us in people culture?
Just some headlines. So month 9 was a particularly challenged month for workforce across the board. You'll note an increase in turnover, sickness, absence rates and vacancies. That reflects the COVID and flu increases during that month, but also the impact, on the additional activity that the Trust was seeing and the industrial action. Having said that, we're still 83 hospital equivalents against our workforce plan for this year, and we're still on track to deliver our workforce plan at the end of March for this year. The bits that we're focusing on to support colleagues with is because there has been an increase in moral injury of the recent quarter, and also because we're asking the staff to do extra because of those pressures. So increased risk of burnout, so we're making sure our health and well-being offer is adapted to support colleagues as best as we can. So that's the main highlights. Thank you.
Thank you, Tina. Any questions or comments for Tina? Christine?
It's not for Tina, it's a separate point.
Oh, do you want to take it now? Or I was just going to move on to finance, but if it's appropriate, let's do it now.
Yeah, it's just really in terms of quality. I'd just like to bring the board's attention to the improvements in getting patients with fractured neck of femur to theatre on time, as this has been a concern of the board for some time. We have had a sustained improvement. We're still not quite where we want to be, but I would say that the fact that we've sustained the improvement in the face of some staffing challenges in trauma theatres, industrial action, and the fact that the patients who've waited a long time to be conveyed to us are in poorer health when they arrive and need more pre-operative optimisation is a credit to the trauma and orthopaedic team, the theatre team, and the team on the trauma ward, and the improvement actions that they've been taking following their away day.
Thank you, Christine, for drawing that to our attention. It is indeed, I did see it in there, but it's great that you highlighted it. And yes, indeed, great progress there. So thank you for that. Neil, finance.
Thank you, Chair. Yes, so just looking at the reports, month 9 position, 1.1 million adverse in the month, bringing us to 1.6 adverse year to date. The common theme from previous months in terms of the large variances in the month, you'll be aware, very much driven by pass-through costs, so things that we're funded for, so the pay award, and excluded drugs and devices from the tariff. So they're very much driving the in-month variances and offset between income and expenditure. But in terms of the highlights, we have received some additional investment income in respect of the robot, the temporary scanners that we've had supporting some of the backlog, and some additional winter pressure funding. Those costs are largely playing out in the variances within pay. So you can see that we have some additional winter pressure costs, banking agency, and our underspend or underachievement, should I say, against the productivity and efficiency programs and features. We've seen a recovery or an updating of our gas and electricity invoices, so we're invoiced retrospectively, and some of those charges have been higher, so we've seen some pressure associated with those. The net position has been offset by some funds from the balance sheet, so release of funds from the balance sheet in line with what we had been forecasting, So at this stage, Chair, I'm still forecasting 19.9 million. It's still in line with what we have previously discussed, albeit the challenges around winter are starting to play out now, but I'm still confident we'll get there by the end of the financial year. Do you want me to move on to capital or just questions?
I am conscious of time, but no, please, if you give us a quick summary, that would be fine.
Right. In terms of our capital position, at this time of the year, there seems to be more money around to bid for, so we are bidding for additional funds for a number of areas, so that will play out in the coming months. But in terms of where we are, we have got a plan to broker forward funds for the end of the year. Still challenges around the overspend on the UEC, but I expect that we'll remain within our capital resource limit at the end of the financial year and be able to move funds forward into next year. Happy to take any questions, Chair.
Great, thank you very much, Neil. Any questions or comments for Neil? No? Okay, so thank you for that canter through the IPR. There is lots of good stuff in there, and I'm sure everybody, some really good things. So, but I thought we just needed to kind of focus our discussion a little bit today. If we're happy to then, we take that for assurance at level 4. Are we happy with that? Thank you. I'm getting some nods. Moving on to committee reports. We only have them from QGC. Julie, was there anything you particularly want to draw to our attention, or do we take it as read?
No, things are covered elsewhere in the board that we've discussed there, so happy to take the report as is.
Thank you, Julie, for that. So, safe staffing. Nurse and then midwifery. Again, in the interest of time, Jackie, if I could ask, and Justine, if we could do it on a highlights basis only, please. Thank you.
Yes, of course. Thank you very much, Chair. So the nurse staffing report for December, which was the November data, is of an assurance level of 6. Key areas, and as we have mentioned, is that the safe staffing levels for the wards in November were achieved. This is obviously against a backlog of lots and lots of mitigations that have been put into place, particularly last minute sickness and covering of sickness. So the use of the temporary workforce has very much been used to support that. 15th and the 20th of December, we obviously had the Royal College of Nursing strike days that took place. We worked very closely with regards to derogations put in for key areas of staffing that were required with the Royal College of Nursing to ensure that we had got our nighttime nurse numbers to meet the patient needs, and no reported harms for patient care, and we did scrutinise that very carefully. Also, as we have referred previously in the meeting, the ambulance strike days that took place obviously impacted for us with regards to ensuring we've got nurse staffing to support patient acuity and dependency in the urgent care work stream. We undertook a acuity and dependency review of patients across our inpatient adult wards, and that data will be included in our January paper going forward. But importantly, I'd also like to draw your attention to December of the ward moves that took place. This obviously does impact for us for our nurse staffing with regards to making sure we've got the right establishment put into place. MAU and AEC, our SCADU and surgical SDEC areas, and we also saw a move for Avon 4 into the beach template and discharge lounge. And the reason I refer to that, because whilst yes, we talk about numbers, also the impact that has on our staff to make sure they're in the right environment with the right facilities, both from a care point of view, but also their health and well-being has been a key focus for us. Our vacancy factor, I'd like to draw your attention to. We did see a rise in our registered nurse vacancy factor to from 161 in October to 178. That's an 8% where it's sitting through. That was driven predominantly because we opened our PDU area. And the key work stream that I know I've mentioned previously that is vital here is our healthcare assistant work stream. We have currently 118 vacancy in November, working very closely with our HR colleagues. Retention is a key area here. We are starting to see the pipeline improving with people coming in. The key bit is how we can support them in keeping them in those areas. They're vital and an exceptionally valuable member in providing patient care to our patients.
Thank you, Jackie. Thank you. Any questions or comments for Jackie? No? Thank you very much. Justine, again, highlights please if possible.
Yeah, good morning everybody. So this is the Safe Staffing Report for December with an assurance level of 5. Just some key highlights then. You'll see our sickness rate just peaked a little bit higher than we've had for a couple of months due to the COVID and flu increases just in the run up to Christmas that we're seeing across the wider organisation. You can see that had an impact on us meeting acuity without mitigations, and we did need some support from our community and continuity midwives to keep the acute areas safe. Our vacancies have remained static and our turnover is now finally reducing, which is really good news. We've got 8 new starters expected in March, April time. So further improvements made in our staffing numbers. We've also got a couple of things that have been happening recently that's further going to improve our position. We had a recruitment event at the weekend which was very successful. We saw about 25 newly qualified midwives come and hear about Worcestershire, and I have to say, if we do manage to recruit all of those individuals, we'll be in a 0 vacancy position by September. Alongside that piece of work, we've also looked at international recruitment. We agreed to look at hosting 6 internationally recruited midwives. We've identified 5 and are interviewing another candidate from South Africa on Friday. So we're really quite optimistic that we will meet that requirement as well. So generally, we are moving in a much better place. So I'll pause there and take any questions.
Thank you, Justine. I don't see any hands raised. So thank you, both of you, for that canter through your papers. That was much appreciated, all the highlights. We have a level 6 assurance on nursing and level 5 for midwifery. Are we happy to take those assurance levels? Thank you very much. So thank you, both of you. Moving on then, Audit Assurance Committee report. Colin, can I ask you for the highlights, or are you happy to take it as read?
Just one point to mention, Anita, we're continuing to focus on the organisation's response to the internal audit report on bank and agency high earners. That has been a major concern. I think we're making progress.
That's great to hear. Thank you very much. TME, is that you, Matthew, who talks about that?
Yeah, nothing to point to. The colleagues will be very familiar with the content of the TME committee report, and it's followed through into subcommittees. So happy to take it as read, Chair.
Thank you very much. I don't see any hands raised. Thank you. In which case then, any other business? Nothing, nobody shouted earlier, so I'm going to assume there's nothing there. So I think I'm going to call this meeting to a close. We do have, if you stay on the line, we do have immediately following this our meeting as corporate trustees. So if we can of our charity. So if you could pull up the papers for that, I'm going to move straight into that meeting. So this is now the meeting of the corporate trustees of Worcester Acute Hospitals Charity. Apologies for absence. Richard Oostrom as previously. Declarations of interest as per the website, and nothing else has been notified. Minutes of the trust board meeting as corporate trustees are in your pack. Is everyone happy with those? Yep, okay, we'll take those as read. Charitable funds report. That's Simon who's the chair. Is there anything you particularly want to draw to our attention, Simon?
Not on this occasion. Happy for it to be taken as read and answer any questions if there are any.
Thank you, Simon. Any questions for Simon as charitable funds chair? No? Oh, Richard.
Not a question, Chair, but as it will have happened by the time we reconvene as a board, worth noting the work that the charity team are doing in partnership with HR colleagues and a number of others on our wellbeing event, which is due to take place on the 1st of March, which touches on a number of the issues that Tina's already raised and is bringing colleagues from all parts of the Trust together to help us get a better understanding of how we can further improve our wellbeing offer for staff at this very challenging time, and the role of the charitable funds in supporting the Trust's efforts to support our staff.
Thank you, Richard, and thank you for highlighting that. Certainly Simon and I will be there, and we're very much looking forward to it. And if there are any other board colleagues that would be interested in participating, I'm sure they could let you know, Richard, if that was of interest. But no, and a very important thing, I think, let's hear from our staff what it is that would help make their lives easier and make them feel better. So I think that's a really important initiative. And thank you to the charity for their support, not only of that, but of many, many other initiatives that we know are supporting the health and wellbeing offering. Lovely. In which case, if there is no other comments or any other business on this one, I don't see any. Thank you very much. I will then bring this meeting also to a close. For members of the public, that concludes our public business today. For members of the board, we will, and indeed members of other committees, we will be reconvening at times that will be in your diaries. So thank you very much, everyone. Have a good day, and we'll speak very soon. Bye bye.